Good evening and welcome to the Tomorrow's Podiatry series, Two Views, where two podiatrists are encouraged to complete some antagonistic cooperation via some friendly debate. My name is Nancy Kelleher and I'll be your host. Tonight we are joined by team captains Zoe Wilson and Liam McManus alongside their expert speakers. Today we are gratefully joined by expert speakers that will be introduced by our team lead. So just to start, Liam, do you want to introduce your expert speaker?
I'll introduce Liam Stapleton, specialist in podiatric medicine, works over in Orpington, Harley Street, but you can introduce yourself as well, can't you?
Yeah, okay. So I'm a specialist in podiatric sports medicine, work in Kent and London. I treat musculoskeletal and sports medicine injuries. That's pretty much what I do.
Thanks, Nancy.
No problem. So to Zoe, let us know what's been happening with your expert speaker for tonight.
So hi everyone. Really nice to be on here again tonight. So essentially, I had an expert speaker around 40 minutes ago, but unfortunately, George Flanagan has been called into theatre. So he's actually dealing with an emergency case down in Northampton. So he's not going to be joining us tonight, unfortunately, but I'd love to get him on for another session. But I do have Ben Lumley with me, who's a specialist MSK podiatrist from Cumbria. I think he's just gone off, but he's going to be joining me tonight as my expert on MRI imaging. So
amazing, perfect. So hopefully Ben will be with us. We are having some connection issues, but we'll do our best for everyone and get him back on and help you out, Zoe, in the fight that you have to take on. So let's go through our topics tonight. Let's go through what the outline of this evening will be. If you're new to here, that would be essential for you guys just to keep up. This is a fast-paced evening and hopefully there's a lot of learning to be done in a concise period of time. So what will happen is we have each team, they will be given 5 minutes to discuss their argument for why one of the modalities has greater benefits in clinical practice than the other, and that is ultrasound versus MRI. Once each view has been provided, each team will then be given time to rebut or debate the argument the opposite team has made, utilising their expert speakers, of course. Following this, we will then have some time to open up the conversation just to the audience and also to ourselves, where we'll discuss your questions, comments, and some of our own questions and comments for one another. And if you have any of those questions or comments, just make sure that you just pass that into our comment section. And we'll get through it, and hopefully you won't be on the fence for this argument and you'll make an opinion at the end. So finally, each team will then have time to summarise their argument as well. So without further ado, let's get down to debating. Just to start though, I won't throw you guys in too soon. I also want to advise our audience of something that we have going on for this evening as well, which is our poll. So we should have a poll coming up for you soon, which basically asks you to vote which instrument is more beneficial in clinical practice, ultrasound versus MRIs. Please, everybody, feel free to submit your vote, which instrument is more beneficial. And then if you are passionate enough, you can even put in your comment why you picked which instrument. You can also pass in your questions if you're on the fence about it. We'll go through all of those, as I said. And then at the end of the session, we'll be able to show you all what was the winner essentially from our audience for tonight, and then we'll have our closing. Okay, so we'll be finished hopefully by 9, but as we all know, in Tomorrow's Podiatry we generally end up talking for ages. We're all podiatrists at the end of the day. We love a good chat. But anywho, let's get down to the questions that are hard to answer. So tonight, Liam, I think you're going to start. When you're ready, I will start your 5-minute timer. When we
can we extend that 5 minutes? This is a big subject as well, and I think we might as well stop it here because George didn't fancy it tonight either. So I think we've won as well.
Right.
Tonight, I'm really hopeful that we're going to really settle this long-standing debate of what's better within clinical practice, kind of really upskilling yourself, or podiatrists, allied health professions, upskilling themselves to utilise diagnostic ultrasound within clinical practice on a day-to-day basis for a lot of patients, or MRI, ticking a few boxes, letting someone interpret some scans, and then getting it back to you. So let's have this debate and open it up. And I'm sorry that George isn't here, but I'm going to direct this towards Zoe. The opposition will obviously tell you that it's more sensitive and specific to review deeper structures using MRI. Yeah, you know, reviewing bones, joints, intra-articular pathology. And look, they're absolutely right. But what's better, really? Using something on a day-to-day basis for the majority of your patients, upskilling yourself and upskilling the profession, or ticking a few boxes. What Zoe won't tell you, and what George was probably not going to discuss today, is the limitations of MRI. It's really expensive. So I refer somebody over here to Orion Medical Imaging, just around the corner, and I can get them an MRI scan this evening, but it's going to set them back around £650. Or I can buy a scanner for £12,000 and utilise it every single day in my clinical practice. There are also long waiting lists. So within the NHS, for example, and not within this private setting that we're in today, where you can get an MRI scan in the evening or tomorrow morning. Within the NHS, there was a case review of a northern GP practice, and they effectively helped the waiting list to see a GP, and they reported in this case study a fantastic 47% decrease in waiting times for GP appointments. But what that actually meant was that you've still got to wait 19 days to see a GP. So when you wait 19 days to see a GP, you're then put into a musculoskeletal clinic or service, or in some instances, GPs are not allowed to or not able to request non-urgent MSK MRIs, and then you're put onto another waiting list. And I can tell you from the British Medical Association that 7 million people, or let me put that into context of where we are. Within London, 3/4 of London are currently sitting on an elective consultant-led waiting list to be seen. Obviously, it's a big limitation to MRI, the time and the waiting lists, but it's also static. It's not functional. There are some issues with BMI as well. So for people who have an increased BMI, you have to request an open access MRI scan as opposed to a closed MRI scan. And with closed MRI scans, you've got claustrophobia. People move, which distorts the images, and then it's interpreted incorrectly by a radiologist that sends you the report back. There are also large slices, and I'm sure Liam will discuss this with you a little bit later, that if you've got somebody with a plantar plate injury, why request an MRI scan when you've got an ultrasound scan right in front of you that can inform your clinical practice immediately, which effectively will change your clinical treatment plan. But tonight, I'm not going to focus on the limitations of MRI scanning. I'm not going to focus on that. We're going to look at the positives of diagnostic ultrasound within clinical practice and the benefits. The question really is, within our profession and within allied health professions, is why do we not utilize diagnostic ultrasound more as a profession? In September 2022, this year, the BMA, the British Medical Association, say that, and I'm going to quote this to you, demand for diagnostic services is on the rise, but a lack of infrastructure combined with staffing shortages means waiting lists are growing. High quality, efficient diagnostic services require a wide range of health professionals, podiatrists. However, over recent years, expansion of key staff groups, podiatrists, have not kept up pace with the increasing demand and activity. So we're not really helping the system by keeping our kind of foot in the door with diagnostic ultrasound. Waiting lists for clinical radiologists have also increased by over 50% in recent years. So really, this isn't, for me, I know it's a debate about MRI versus ultrasound, but for me, it's a call to action. It's a call for podiatrists to really start to upskill ourselves and move with the times. Utilize diagnostic ultrasound as a first point of call with a wide range of MSK conditions for a vast and a mass amounts of patients within your clinical setting, instead of waiting until an MRI might be specific and ticking a few boxes to send away. I've got 8 seconds left. Okay, we'll have to skip a few. I'm going to leave you with a closing sentence. Whether your undergrad or postgrad ultrasound should be part of our profession's DNA.
Thank you so much. Well, he's very confident, Zoe. I feel sorry for you. Well done. I know, that's perfect. That's what we want around here. Okay, Zoe, so are you happy to start your argument? Do you want me to get the timer ready?
I need you to bring up my presentation, please, for Team MRI.
Perfect. I'll make sure Michael's on it. There he is. Perfect. I'll start the timer. You ready to go?
Can I just, what I will say is, I would like maybe a smidgen long, like even
absolutely
20 seconds would just help.
I know.
One of the comments I'm raising is actually something that George really wanted to raise, but obviously can't. So yeah,
I think that's fair. I think we're struggling to get Ben on this evening. Are you happy for that to go ahead, Liam?
Cool. Yeah, absolutely.
Yeah, let's do that. Okay, I'll do 5 minutes, but once it stops, I'll just kind of let you know just that it's over and you can just keep going. Cool.
Thank you.
Let's go for it. I'll start it.
So, good evening, everyone. Thank you very much for your small presentation on ultrasound there. I know there's a lot to fit in that time scale, and I hope I can do MRI some justice. I use ultrasound myself in clinical practice, and I absolutely love it. And today even thought to myself, why am I entering this debate? Is there a debate? But you know what? I'm going to try anyway. So Team MRI is myself, Zoe Wilson, and George Flanagan was going to be here, but isn't. So next slide, please. I feel like Boris Johnson. Right, so common uses of MRI in the foot and ankle. We're going to talk about the benefits to podiatric clinical practice and why choose MRI over ultrasound. Next slide, please. So we're going to jump straight into it, very wordy, I'm afraid, but with inflammatory arthropathy. So early manifestation has been shown to be seen in rheumatoid arthritis in a number of different studies on fat-suppressed and contrast-enhanced sequences, picturing erosion, synovitis, and tenosynovitis. So in a study by Bauer et al. In 2019, looking at 840 joints and 700 tendons, MRI was shown to be the superior in sensitivity and recognition of early stages of inflammatory arthropathies, mainly focused on synovitis and tenosynovitis. So it gives us an accurate appreciation of inflammatory lesions within bone, so not only extrinsic, but intrinsic to bone. So such as bone marrow edema, bony erosions associated with inflammatory arthropathies. Specificity in tissue characterization and relevance to neighboring anatomy, we get that complete view with an MRI image that we don't get with a snapshot image in ultrasound. We get to look at staging of different arthropathies, such as juvenile arthropathy, poliomyositis, and ankylosing spondylitis. There's a range of different studies of which I have the references that kind of back up the use of MRI for staging of those different arthropathies. We've got unparalleled tissue contrast with exact delineation of the anatomy involved. Next slide, please. Next slide, please. Sorry. So earlier recognition leads to earlier diagnosis, prognosis, intervention, and earlier disease modification in these patients. You cannot argue with gold standard. Next slide, please. So jumping into stress fractures, is MRI really better? And we've proven that with a systematic review by Wright et al. In 2016, which showcased the highest sensitivity and specificity amongst a range of different imaging modalities for lower extremity stress fractures. It allows us to grade the fracture and predict recovery time and intervention type. Early detection of bony changes such as periostitis, soft tissue, and bone edema. Identification of alternative differential diagnoses is just not possible with ultrasound. It's non-specific, and so metastatic disease may well be one of those differentials. Next slide, please. So soft tissue and bone masses, MRI is superior in diagnosis of soft tissue masses compared with other imaging modalities. Again, I chose the most recent one there. It's been a long-known phenomenon that MRI is the gold standard. Not the gold standard. Biopsy is the gold standard. But what MRI allows us to do is aid biopsy planning by showing us an appreciation of neighboring anatomy, giving us one clinical area of interest, such as the foot or the ankle. The duration of diagnostic workup is reduced. Earlier diagnosis guides efficient and in some cases life-saving management. The specificity in tissue characterization cannot be challenged. Next slide, please. So in podiatric clinical practice, what are some of the conditions that we see? What are some of the conditions that we would utilize MRI? So tarsal coalition, whether it be osseous, fibrous, or cartilaginous bridging of the bones involved, we get a three-dimensional view that we can manipulate at any time. Tarsal tunnel syndrome, so some of those neighboring space-occupying lesions that cause tarsal tunnel syndrome, we don't always get an exact reason, primary reason as to why tarsal tunnel occurs, but with a three-dimensional tissue characterized image of the highest quality is going to show us that. Lisfranc injuries, we get a higher contrast of detail with Lisfranc injuries, which just cannot be seen on ultrasound. Flat foot deformities, we get appreciation of ligamentous, tendinous, and osseous structures in 3 dimensions, but we can look at all those things in the same image. So it reduces that diagnostic workup time, diagnostic accuracy. We know it's the gold standard in a variety of different MSK conditions. We can grade osteomyelitis, whether it's acute or chronic, and stage that, as well as septic arthritis. Image manipulation is repeatable, and I just can't say that's the case for ultrasound. It's a definitive imaging modality. There's no need for repeat imaging. We get the answer in one image. Next slide, please. So what's wrong with ultrasound? So the anatomical location is limited to superficial structures. We know this. There's reproducibility concerns if we're going to go back and look at that image. It needs to be appropriately labeled, and we only get a snapshot of where we're looking. It's operator dependent. So is that image being interpreted by somebody who's trained appropriately in that specificity in that area of the body? We know that there's issues around governance, and whether or not we'll touch on that this evening, I'm not sure. We'll ask Liam. Anatomical location and neighbouring structures, I've already mentioned. And intrinsic features of bone, we can only see cortical detail with the use of ultrasound with the probe view. Image enhancement and quality is superior, and detection of failure in meniscal ligament, tendon, and bone injury is superior. Next slide, please. So to conclude, it's a high-resolution 3D unparalleled image. It's reproducible 3D imaging depicting extrinsic and intrinsic depth anatomy. Could you live without MRI in your podiatric MSK practice? Think about the iceberg, think about what we can see, and think about what's below it. That's it.
Amazing. Thank you so much. You didn't even go over that much. It was only like 30 seconds, so amazing. Well done.
Thank you.
No worries. Just had a chat with Michael as well. I think we're still having difficulties with your expert speaker. If our extra Liam, so our expert Liam, if he's happy to chip in with kind of rebuttal on both sides, if that's okay with the other Liam McManus. As long as everybody's comfortable doing that, Ben is also going to jump onto the comments and also bring in a bit of his opinion here and there as well. All right, is everyone happy with that?
Yeah, absolutely.
Yeah, thanks.
Amazing. Perfect. Apologies anyway to everyone listening. Hopefully we'll get Ben and we'll get George back on another date, and we'll have these conversations in future again. But anywho, so I will still invite our expert speaker, Liam, just to give a short rebuttal. You have 5 minutes. We seem to be kind of going over. It's absolutely fine, especially if you're going to be talking about both cases, but you can maybe split them up yourself and go for 10. Let's see what you got.
I'll just start with ultrasound.
Perfect. Ready to start?
Yeah, you're going to talk to us about your one-stop shop, aren't you, today?
Yeah.
And actually, what we talked about in terms of musculoskeletal ultrasound, how you utilise that within your clinical practice.
Yeah, that's right. So what we're going to show you now, we've really got video to play. Some of the points that Zoe made are very appropriate. That MRI is more sensitive and specific for certain pathologies. Ultrasound is also gold standard for its own list of podiatric pathology. The difference is that for an MRI is getting the scan isn't always that easy, and certainly for early stage inflammatory arthropathy on the NHS, I think rarely would be someone get an MRI very quickly. Ultrasound, if available in clinic, as we'll show here, might take 2 minutes to do a scan and would show up early signs of those inflammatory arthropathies and may dictate the necessity for further scanning to differentiate between a list of differential diagnoses. And this includes the inflammatory arthropathies and bone stress reactions, bone stress fractures, and other intra-articular pathology that indications of injury and disease can be picked up and may speed up the possibility of having MRI. I can play my video here on a normal consultation. I would still run through a normal history taking and physical examination exactly the same as everyone else. In clinic, I would have an ultrasound scanner either with me in the room or next door, and would have access to that whenever I needed it during my clinic. Do you want to play my video, Michael? You got it there.
Absolutely. Just one quick moment there, George. I'm going to need you to unmute your mic when we play the video. Otherwise, we won't be able to hear you giving us a wonderful description. Okay.
Yeah. Okay.
Sorry, just going to jump in if everyone can hear me. Liam, are you unmuted for the video?
I'm just coming in here.
I think you have to unmute yourself even if you're behind the scenes.
Yeah. So sorry about that. We have a short walk into
No worries.
Into the ultrasound room in my radiology department from my consultation room. I can perform an ultrasound scan and show the patient the relevant findings. Patients love that, and this dictates treatment. Now, I estimate that for the case that I see, 75% of injuries that I would see, I would be able to make a firm diagnosis based on MRI scan, bearing in mind a large array of conditions that might be well be missed by MRI, including neuroma, neuromuscular complex, and plantar plate injuries are often missed on MRI. Having a dynamic scanning technique where we can see the interruptions to the plantar plate when we move the toe is vital in making those diagnoses. Very often I have seen bone stretch reactions, cortical sclerosis on a bone, and as Zoe says, we may well think, I've seen them before bad enough to look like metastases, and that's important. But what that informs me is better write a referral for an MRI scan immediately in clinic and get that scanned as an emergency. Had I not had that, we might be thinking that it's a simple bone stress reaction, and that may be a normal waiting time. So these things inform clinical decision making. I had a patient in today. I've seen him before for a different injury. He had a flare in gout, which is reasonably simple. We ran through the normal examination as today. We did the scan, diagnosed the gout, and performed a guided corticosteroid injection in clinic. And he said that he remarked in the consultation that process had he been seen even privately by, let's say, an orthopedic foot and ankle surgeon, who would then refer out for a scan, then return for a follow-up, and refer out again for the relevant injection. would have taken 4 weeks at best, and that's true. To come in within an hour, you have diagnosis and treatment administered, and we expect within a week he'd be pain-free. Obviously, continuing some of that debate onto MRI, it is vital. And like Zoe said, I run a lot of MRI scans too, in no small part because I'm a bit of a stickler for an accurate diagnosis before we start. If there's any doubt, without shadow, MRI has its uses, and it is vital. Some of the conditions that Zoe mentioned there, absolutely would you run an MRI, and certainly if you suspected a tarsal coalition, then you know from history taking physical examination, not needing to do an ultrasound scan to pick that up. That's an MRI. I think probably the take home would be the history taking is vital, and almost all of the information you need to make that clinical decision should come from a good history that's supported by a physical examination. And strictly the consultation with me, and I don't know about you, Liam, but the history taking is the longest portion of my consultations. The physical examination in some cases might be there or there, that dictates the diagnosis. This bit moved, I moved that one. And very often it doesn't need to be greatly involved to make a firm and accurate diagnosis. How are we doing on time? Well, I can't see the camera.
No.
Just let me talk now. Yeah, just off I go. I did this for an hour and a half.
No, you've done very well. Thank you so much, Liam. I'll offer for Zoe to come in. Zoe, do you have anything else to add to the rebuttal? Do you have anything that you kind of noted that they brought up that you're kind of like, But if not, then
I like the fact that I'd rather this was just like discussion, like Liam's just like rebuttal. That feels that feels like a lot less pressured. I think Ben's just commented it also allows for pre and post contrast imaging. So yeah, I mean, with regards to ultrasound, the reality is that, I use it every day in practice. I've used it 4 times today. And again, having a word with myself thinking, have I really got this argument, when I'm kind of talking about something I can't do in clinic? I think there's times when we use ultrasound and there's times when we use MRI. Now, I've had a patient recently who's had tarsal tunnel syndrome. She's been to 2 other people who haven't diagnosed it appropriately before she came to see me. She'd actually been sent for nerve conduction studies by her GP. And that had kind of come back that there was some abnormality at the level of the foot and the ankle. And then what we did was we sent her for an MRI, and it showed that she had a 2 centimeter large ganglion that was lying posterior to her talus. And that's not something that I'd be able to pick up on ultrasound, And obviously when we're dealing with masses as well and the diagnosis of lumps and bumps, we kind of know that in terms of the delineation and characteristic of that mass is that we can't really effectively utilize ultrasound for those purposes. And certainly I know George had a really good case that he was going to share about a patient who again had tarsal tunnel syndrome, and she had a large tumor that was spanning basically the lower third of her leg and right down below her calc. And that obviously is not going to be picked up on an ultrasound because it's a very superficial view. It's a snapshot view. And so you might see kind of what would appear as a swelling, but and maybe some power Doppler activity there, but you wouldn't be able to sort of delineate the size of that mass. And unfortunately that patient, it was a little bit too late in terms of her symptoms. They came on and, it wasn't picked up early enough. I think Ben is writing some things. I don't want to ignore him.
So Ben, come in.
Plantar plate injuries. It's superior in determining the grade of injury. Now, I would agree that plantar plate's a great one to look at in clinic, but I think it's your clinical exam. I think it's your history taking that really gives you the diagnosis of a plantar plate tear or rupture. And that's often in positioning of the toe, the symptoms that they kind of sort of lay out to you. That feeling of walking on a pebble, the toe might be deviating, the pain at propulsion, you know. A lot of this is about clinical examination, but I think when it comes to kind of a detailed image, a 3D image, one of the other comments that I'll raise is returning to that image and being able to spin it and look through every different slice of that image. You know, I think sometimes that's difficult because if you take an image in ultrasound, it's just a 2D image. With MRI, obviously, we can look at a 3-dimensional view of anatomy and a lot of anatomy and how it sort of behaves towards other anatomy when there's a pathology and, you know, things like that as well. I mean, I kind of use MRI for specific pathologies, and it picks up things that, you know, you don't always expect as well. And sometimes there's always that conversation of, does it give us too much information? And, you know, do we start to, you know, arouse anxiety with patients whereby we're imaging unnecessarily? Are we going to act on that image? You know, that's the thing. What I like about ultrasound is that we use it as part of our MSK assessment. I do believe that plantar heel pain is, and I know Ben agrees with this, but plantar heel pain is a complex pathology. And ultrasound, again, it'll show us a thickened fascia. You know, it'll kind of show us if there's maybe some fat pad atrophy and things like that. But if we're looking at kind of where, you know, using things like contrast to identify inflammation in some of those structures, we can identify bone edema. So if a patient's got plantar heel pain, we can't tell if they've got bone edema with ultrasound. But what we can do is if we get an MRI and we've confirmed that, we can say this is going to take a lot longer to get better, you know, and it allows us to kind of counsel the patient on that aspect of things as well.
Absolutely. I was going to jump in just there. Even it's something that you guys have brought in for ultrasound, is the ability to kind of teach our patients about their own conditions, patient expectation management. And I guess that's something that definitely is a part of ultrasound. Have you used MRI, anyone, in that kind of ability to provide that information? I guess MRI is a lot more complex to look at. There's a lot more to see. Has anyone used it as a patient education tool within their practice, or has that not happened?
If I could say that, guys, but we use everything within our toolbox to educate the person, so that, you know, if we're using diagnostic ultrasound, for example, and we are, let's take your point of reviewing a medial ankle, and you've got a ganglion posterior to the talar sewing. If I'm not seeing anything on an ultrasound, then simply I'm referring on to an MRI scan. So both things kind of have their place, and I think our argument really is that it's a lot of the things that we see commonly in practice we can pick up under ultrasound. The other problem with plantar heel pain, as you mentioned, is that actually, yes, we can differentiate between a tear, a longitudinal tear, a cross-sectional tear, a bursa, for example, or a fat atrophy or a fat impingement syndrome. But actually, you know, patients then, I'm rebutting my own argument here, but patients then sometimes rely on that scan, and they come back to you to see if the plantar fascia is then less thick or less swollen, or you know, is the micro damage caused by the fascia is it better? Well, your history will tell you that. So nice guidance and certainly best practice isn't to scan everything, but when it's needed, and I'm going to come to Liam in a second, when it's needed, certainly for plantar heel pain or some of the common things that we see in clinical practice, ultrasound is great as a tool, as long as you are competent.
Yeah, I think coming back to your question, I think, if you can, I can put up my MRI scans on the computer at clinic, and I would necessarily show patients, certainly a patient who is finding it difficult to understand what the problem is. So I had a patient recently that comes to mind, a fairly elderly patient, but incredibly active, incredibly sportive. And she would run 10 miles 3 or 4 times a week. She's about 75. She'd had knee surgery, post-menopause obviously, and had an insufficiency fracture to her calcaneus on returning to running. This woman was running for a good few weeks on a full stress fracture. Being able to show her definitively that fracture line on her heel and why she needed to go and have bone density scans done is essential, and certainly it reinforced the fact she needed to have a fracture boot on and she needed to stop running, because in all honesty, without that she probably wasn't stopping running, she'd have carried on. So to answer that, yes, to use MRI like that, certainly if you can make sense of the pictures to the patient, it is really, really important, and you probably have to pick your patient. I think certainly on that point as well, you don't scan everybody, but it is I think I view ultrasound more as an assessment tool within the clinical setting. And I have assessment tools. Liam's got to get 3D gait analysis here. He doesn't run gait analysis on everyone who comes through the clinic. It's not necessary, but there are patients for whom that informs your management plan. And I view ultrasound in the same way. And like you said, when I get asked this question, patients about re-performing an ultrasound scan post shockwave therapy on a patient who's got no pain, I explain to them that if they were a professional footballer, that they wouldn't be re-scanned. They're treated on their pain, their symptoms, and their functional ability for their return to play. And for a simple plantar fascia or Achilles problem, they wouldn't be re-scanned. And if they were, the chances of them seeing a normal scan 6 weeks later is almost zero. That they would still have pathology and can have pathology for the rest of their career on scan. And I explain that to people. People do understand that when you explain that to them.
Just on kind of elite sports people as well. Obviously, you've got an Achilles tendon, and nice guidance says that for an Achilles tendon pain or pathology, you do not need an X-ray, an MRI, or an ultrasound. But actually, from an elite level point of view, and then if you ultrasound someone and you see some neovascularization of the midsection of the pathology, it's going to change what you do with them.
Absolutely.
But you might then want to consider osteal injection versus high volume injection.
Yeah.
And you wouldn't necessarily then consider shockwave therapy, but you can track it again, can't you? So I'm just pointing to Zoe here because it is repeatable, in the right hand.
And if you can't view the images yourself with an MRI scan, it's just as user dependent as ultrasound. And we've all done referrals, and the radiologists have missed specifics that we might. Certainly, when I look back, and in clinical practice, I've gone back and I look at every scan. I won't do anything until I've seen the images. The first patient I had that taught me that lesson, set a patient off on suspicion of a sesamoid stress fracture that was written in the MRI request, sent off. A week later, she comes back with a report saying no sesamoid injury. I had booked her to have an injection, and I asked for the images. It came through half an hour before her injection appointment. I reviewed them, and she had an avascular necrosis, and we wouldn't want to be injecting that. And so, making that differential diagnosis, being able to see those images, otherwise it's just as user dependent.
Absolutely, because that's the other thing I think that we, and it's something that's definitely coming up in research, is how, and you've all kind of alluded to it, but the how pain might not equal what we're seeing on imaging, and so that repeat scan is not required. But even sometimes you might scan someone, and what you're seeing doesn't relate to the pain that the patient is describing, or it might completely change what your treatment plan is, and you're kind of like, but which one do I go for in my clinical findings, the symptomology, or what's coming up on image? Do you find that that's a struggle in practice for anyone?
Only when lots come up. So I've got a patient, and she's a really elite level swimmer. And when she swims, she gets no pain. When she runs, she gets a lot of posterior ankle pain. And all the symptoms point towards posterior ankle impingement. But send her for an MRI scan, because again, that's probably a thing you can't see on ultrasound. MRI scan came back, she's got about 5 or 6 different pathologies. And you have to sift through that using history and clinical judgment. And if you're not sure, the kind of old-fashioned way of doing that would be perhaps to perform a guided local anesthetic injection And so when you have ultrasound in the clinic, you can do that. You can pinpoint what structures you know, you can localize with anesthesia without affecting the other structures, and you can work your way through diagnostically and unpick some of that without put the patient through any undue risk. I always say not to treat a patient like a pincushion. We're not going to be injecting everything that comes up on the scan. We've got to find exactly what it is before we decide to treat.
So it's not treating this scan, is it?
Yeah.
It's effectively treating the patient.
Yeah, that's it.
I think what we have to remember as well, with any means of imaging, is that we're using it to aid diagnosis. And that's the key thing. I was kind of always taught that 80-90%, if not more, is our clinical history taking, clinical assessment. And I totally agree with you with regards, the obsession of imaging, the obsession of diagnosis and looking at structures even 3 months after shockwave. Like these structures are not always changed ultimately. And I think there's some things we know about shockwave, for example, and there's other things that we don't. But the reality is that we're kind of monitoring the functionality scale. We're monitoring the pain scales essentially. The other thing, with regards to MRI scans is that, yes, we are getting a radiology report, and there are going to be instances where there's going to be aspects of that image that, we potentially would question. I also wanted to pick up on your point about Achilles pathology and the benefits of both MRI and ultrasound in picking up on pathologies related to an Achilles pathology. So if you've got an absolutely huge retrocalc bursa anterior to the tendon, and you're seeing your patient in clinic, and those comments about the research surrounding Achilles and, do we need to image them? Well, absolutely, yes, we do. I would say that since I've started using ultrasound, again, rebutting, your argument, my own argument, but there's a lot of those cases whereby, they've been told they've got a Haglund's deformity, and actually they've got a soft tissue mass on the back of the heel as a result of the retrocalc bursa, or the superficial bursa. But what we can't do if they've got an insertional Achilles problem is treat that tendon problem in isolation when we've not addressed, the bursa in the first instance. So, yeah, so it's been an interesting discussion, and I don't know whether there's whether there can be a winner, because I love ultrasound and I love MRI for its own reasons, but
there's no definitive, is there? But each kind of modality of imaging has its place. But to kind of pick up on your retrocalcaneal bursitis, for example, yes, nice guidance doesn't say image. Yes, you can, blah blah blah. But in reality, the amount of podiatrists at the moment, certainly at undergraduate level, just don't get exposed to diagnostic ultrasound and MRI scans. But it'd be really good, and this is again a call to action for the universities out there, that bring it into the curriculum, bring it into undergraduate study. And certainly when me and you trained many years ago,
Too many years ago.
I was already about 14 years ago, but we never explored any diagnostic ultrasound at all on our placements in specialist clinics. And if George was here, I actually shadowed him when he was in clinic as well, when he was a staff podiatrist at Blackpool, and we didn't have ultrasound then either. But is that your?
Yeah, we didn't. There was no discussion about it at all. I don't think, from memory, it's a long time ago now. But yeah, I don't think we learned about any imaging modality whatsoever. I think at MSK, when I was at uni, it was almost not discussed. The MSK pathology was taught as biomechanics, and there was basically walking gait analysis, and you might have done decided whether someone has a foot posture index of X or Y, but that was about as far as that went.
Yeah, I mean, I think we can all say that imaging in one way or another, and I know Liam will agree, both Liams will agree, that imaging in whatever method has transformed our practice.
Yeah.
It will change your practice, but you also have to be careful, and we have to be cautious around diagnostic ultrasound, because I wouldn't image everyone, and there are certain things that I've imaged that I've not liked. So, for example, a giant cell tumor that we've had to 2-week wait, specifically somebody. I've imaged where I've then seen a ruptured Achilles tendon and thought, right, now obviously my Thompson test was negative. I'm going to image. I know it's ruptured anyway, but what do I do with that? Is that then going to change my kind of clinical practice? One thing I do want to kind of rebut, I know we've got a little bit of time, is plantar plate kind of injuries. We've touched upon them a little bit, but you mentioned, Zoe, within your slides that you have one image, but what if that one image is 3 millimeters in diameter? And what about if that one image completely misses the plantar plate, or in fact a neuroma bursa complex? And there was a research article recently, 2021, by Catherine, I'll have to get you the Catherine McCarthy, I think it was. It was the PubMed, and she's a clinical radiologist, and she advocates basically for plantar plate injuries specifically that it's gold standard or a better practice to do diagnostic ultrasound. But I agree with you that in terms of clinical practice, you're going to do a modified Lachman's. You're going to know that's injured anyway. You might have some capsulitis, but diagnostic ultrasound certainly takes you to that next level in terms of interpreting that information and not necessarily reporting on it, but it informs your clinical decision making when it comes to a treatment plan.
I think, the other thing is that you can dynamically assess that structure with ultrasound.
You're agreeing with me, are you?
Yeah. Pathology. Just with this pathology, Liam, yeah, just one. But you know how it is, when you're assessing the plantar plate and you're looking at the dorsum, you're looking at the capsule of the joint, you're looking to see if there's any effusion, and then you can move plantally and you can look at the integrity of the plantar plate. You can look across the central, medial, lateral portions, and you can stress that structure at the same time.
It's an incredible tool, isn't it, that we've now got, and hopefully the Royal College of Podiatry is looking at a potential framework for podiatrists utilising it. But in September 2022, the BMA, the British Medical Association, have called us, have said to us that we need to upskill ourselves because we need to increase the demand. So it's also something that if it's an area of interest, certainly within MSK or beyond, or podiatric surgery to guide injections, for example, it's something that you can absolutely utilise, but just obviously checking the frameworks around that.
So I'm going to jump in. I know we're all very happy in the MSK world just now, but we do also have Sean Savage's comment here. So this is more bringing in our high-risk patients, particularly those of vascular. It's something that we haven't really touched on for this evening. Of course, on X-ray, we kind of know what we're seeing. We see some vascular calcification and such. How do we think ultrasound and MRI can work in the high-risk foot or the vascular or ischemic foot, I mean?
Do you want to say that, Liam?
Yeah, so you can, and obviously I think not everyone will do this, it's not something I do in practice, but certainly you can use your ultrasound scanner to measure the Doppler signal on an artery. You can use it if you're suitably trained, although I'm not sure the standard courses do that. To look for deep vein thrombosis, and that is commonly used by radiologists. So if you suspect a DVT, one of the things that we've done after the blood test would be a referral for ultrasound to have that assessed, and whether that falls within, certainly it doesn't fall within my scope as an MSK in sports, but certainly if you're in a vascular team and you have ultrasound skills, that makes a lot of sense that you would be able to perform that scan on another limb and look for a DVT.
It's understanding your scope of practice, isn't it?
Yeah.
And if this is completely outside of your scope of practice, which for me and you it definitely is, then I wouldn't necessarily be using it for veins, looking at DVTs, or any arterial flow. You can use a handheld Doppler for looking at your arterial flow.
Yeah.
I think there's podiatrists in our profession that work within high-risk patients and vascular examination with ultrasound. I know Sean's commented that Emily Howarth does use it in her high-risk patient setting. So I think there are people who use it within our profession. I personally don't know enough about it to comment. So I appreciate Liam's comments on that and Sean's as well. But I think it's something we need to learn more about.
Absolutely. It's something that seems to be coming up in research as well. Even within the immediately healed foot, looking at elastography, using ultrasound, that's definitely something hopefully coming out for the high risk foot, understanding what type of tissues there and the maturation of tissue following a wound. And then of course, even looking at like the Achilles tendon and its involvement in kind of forefoot pressure and such like that. It seems like it's an expanding world of imaging that we have in front of us, which is even more exciting. And hopefully with our case accreditation and getting more of an involvement of the framework for podiatry, and then of course getting more mentors out there, this can become a part of both the high risk foot setting and complex MSK. So we also have Susie. Susie brought in a comment just with regards to plantar plate pathology rarely correlates accurately. And that the intra-op and imaging reports, sometimes the radiologists maybe don't understand the pathology well enough. So maybe that's where we're kind of seeing that we see those reports and we come back with a bit more info for the radiologist to create a confirmed diagnosis for that patient. Also, Sean's brought in another comment just to finish us off. We saw it used at PSM conference last year when radiologists assessed vascular supply of lower limb. Was outstanding seeing it employed in that area of an athlete. Yeah, so hopefully this is just going to be getting bigger and bigger. We might have to come back in a few years, get over all of this stuff, get some high risk pods involved as well. But just to sum up, I didn't even give you enough time to even chat, and I knew it would happen. But Zoe, if you want to give us a wee summation of your discussion today, and then I'll head to the two Liams.
Oh, well, it's been fantastic. Thank you, everyone, for listening to my presentation regarding the uses of MRI in podiatric practice. I think ultimately MRI does give us delineation of structures. It does give us that high quality image. It does allow us to employ such things as contrast to identify different structures, the different sequences that we can utilize with MRI. I do believe there's a place for everything. And I think rather than a debate, it's been a discussion. I've absolutely loved listening to our resident expert, Liam Stapleton, on some of his comments and experiences in clinical practice, both with MRI and ultrasound. Really sad that George isn't here, but I hope he's getting on okay in theatre. But no, ultimately, MRI, it's the best of the best in terms of three-dimensional soft tissue and bone imaging, but it's not always relevant. In some cases, it's the right approach, and particularly with its use in flat foot, tarsal coalition, tarsal tunnel, stress fractures, in the high-risk foot with osteomyelitis, septic arthritis, and in arthropathy. And some of the more common MSK conditions that we see relating to the heel, I do feel that it is superior in those areas. Thank you. Thanks for listening, guys.
Thank you, Zoe. Right, I'll move it on to Liam McManus if you want to start with your summation, and then finally our expert speaker of the evening can chip in at the end.
Yeah, well, first of all, guys, thank you very much for the discussion. Zoe, Liam, Nancy, and Michael in the background that's kind of tapping away, organising everything for us. Thank you very much for inviting us. And it's absolutely a great topic and a great debate. And I don't think I set out tonight to settle this long-standing debate, and it will really linger on and on and on. Even Bracky is getting interested now as well. So look, thank you very much for kind of listening and tuning in on at 8 o'clock till 9 o'clock on a Tuesday evening. I'm pretty certain we put a good argument across that, podiatrists in general, for us, if you're getting bored in clinical practice or you're seeing lots of routine patients, I'm going to tell you that every patient in front of you is a musculoskeletal patient. And if you want to upskill yourself, then diagnostic ultrasound can absolutely do that for you, as well as upskilling within 3D anatomy and functional anatomy as you're reviewing your patients as well. But ultrasound diagnostic MRI scans certainly have its place. But yeah, I'll hand over to Liam now.
Thank you. Thank you for having me, everyone. That's been great. Yeah, I think there is, from my take, there's not a debate which one is better. I think both have an essential place. I think the speed and functionality of an ultrasound scan in the right hands will change the practice and it improves the patient journey no end. An MRI is an essential part of my practice. I have been able to turn an MRI round in less than a week is unbelievable, certainly in the sports medicine setting. You can't get away from one isn't better than the other, but they are both brilliant and essential tools. I think probably the skill involved, but also knowledge is probably more important than the skill. So don't just upskill yourselves, increase your knowledge. We always should be learning. Like this, there's things that we all pick up on. Another person's take on how things are done, the latest evidence. Having the knowledge to know when to choose what and what's relevant and what isn't, and what your shortcomings are, especially if you've got an ultrasound. That just because you don't see what you expected to see on an ultrasound, the idea then would be perfect through MRI. If your clinical judgment tells you there's a problem and you don't see what you're expecting to see, then either get someone else to scan it or run your MRI. Because just because you can't see it doesn't necessarily mean ultrasound is not there. Obviously, there's a lot of skill, a lot of experience that comes down to both the regulars reporting MRIs that Susan Spears made that comment. That certainly, if they're not used to seeing people, they're not sure what you're looking for. These things are easily missed. Just as an ultrasound in your hands, you're not used to seeing particular structure or particular pathology, that might be missed too. I think that it's not one or the other. I think it's both. Hopefully, I'd like to see more of you using both in clinic.
Amazing. Thank you so much, Liam. So that's us over 9 o'clock as expected. But just to finish off, I also wanted to let everyone know what our poll results were. Kind of what we are maybe seeing with what we were all discussing. We have 40% going for the MRI and we have 60% going for our ultrasound. A few votes in, it wasn't a lot of votes. Hopefully we'll get more as time goes on, and people can also come back and watch these videos and comment as well, and hopefully one of us will pick that up as well. But thank you so much. Like all of us have said, we really appreciate all the involvement from our audience. And if there's any questions, hopefully we'll get back to them if you pop them in our comments at any point. And I hope you all have a lovely evening. And thank you to our expert speaker as well, of course.
Thank you.
Thanks, guys. See you now.
Thank you.
Bye.